Hello, good day. I'm Dr. Henry Dimaano. I'm from the Philippines. I decided to make an English version of this presentation. The first one was in my native tongue, in Filipino, in Tagalog. But I'm doing an English version for the international audience. I would like to discuss what UBE spinal surgery is, unilateral biportal endoscopic spine surgery. This is the type of surgery that I now do for my patients with degenerative spine conditions. I've done them for cervical spines, for thoracic spines, and mostly for lumbar spines. That's usually the most common complaint. So let's go into it. Let's dive into it. Okay, endoscopic spine surgery is nothing new. Most people think that it's new, but it's actually not. It was birthed during the late 70s and was developed during the 80s. The pioneering work for endoscopic spine surgery was done by this man, Dr. Parvis Kambin. He's an American Iranian doctor. Independently, Dr. Sadahisa Hijikata, a Japanese spine surgeon, also came up with basically the same approach. They said, can we access the spine using a small hole without even seeing what's actually here, without opening this area? Just access it with a long tube and attack the disc if there's a disc herniation that's compressing the spinal nerve root. Can we remove that without needing to open up the muscle and stripping the muscle from the bone and making a big bone opening? So that was their initial objective. And because of the pioneering work of Dr. Kambin, this area now, the approach area where endoscopic spine surgery makes use of, where the endoscope goes. This has been named as the Kambin's Triangle in honor of Dr. Parvis Kambin's pioneering work. Now, during the 90s, the scope that would now be accepted as the standard scope used for endoscopic surgery is this scope. Invented by Dr. Anthony Jung, or designed by Dr. Anthony Jung. It's basically a jacket and a scope, a sleeve and a scope that goes here in this area like this. You approach the spine from the side, not from the back, which is the traditional approach. And then you land here in Kambin's triangle and do your decompressive work. Now, all the tools, the scope is inside this barrel, but all the other surgical instruments also go into the barrel. So that's why it's called uniportal, because you only need to make one big hole, one port for the instrument, and everything else passes through this channel all the way here inside. Initially, they were using this to remove the soft material of the disc, but they also recognized that sometimes there are bony pathologies. There's an overgrowth of the facet joint, particularly. And Dr. Thomas Huglan was one of the people who designed the earliest drills, the endoscopic drills that are used to trim the bone in this area of Kambin's triangle. Around the time of the early 2000s, 2003, if I recall correctly, the Korean spine people started pioneering their own version of uniportal spine surgery. They basically call it biportal. Biportal because there are two ports, there are two openings, one for the camera and one for the working instrument. If we have Kambin's triangle for a uniportal approach, a lateral approach, in biportal spine surgery, since the scope that we're using is a bit shorter, we cannot approach from this angle, but rather we approach more from the top, from the back, going down, following the more classic interlaminar approach. Okay, the area where we dock, this area over here, where we start or we do most of our work, is named after Dr. Sang Kyu Son. It's called the Son's Triangle. So primarily these people over here, Dr. Son, Dr. Yum, Dr. Choi, Dr. Hyo, Dr. Cholwong Park, the spine surgeon who taught me unilateral biportal endoscopic spine surgery. So these guys and a lot of other Korean surgeons started trying out this technique and basically developing instruments, new approaches. And so beginning during that early time of 2003 until now, they have gone through several generations or iterations of the technique. They are now doing biportal endoscopic fusions, T-lifts, X-lifts, and such, tumor surgery. Definitely, this biportal technique has extended all the way to thoracic and cervical approaches. So this is the appearance of biportal surgery. The uniportal surgery approaches from the side, but biportal surgery approaches more from the back part, the top, using two small holes. Okay, let's dive into the main concepts. Minimally invasive approach to the spine. This is characteristic of any endoscopic surgery technique. But for biportal, we make use of two holes. We want to do this. We want to approach the spine because we decompress any kind of nerve or even the spinal cord that is being compressed by degenerated pathologic structures. We want to preserve the stability of the spine. That's one of the advantages of doing endoscopic approach. You make a very small surgical footprint. You do not destabilize the spine. You want to directly approach the area wherein compression is happening because you want to decompress that area. You do not want to, loiter around any other area that doesn't need any kind of surgical treatment. So it's very pinpoint, it's very targeted. This is the classic approach, if I may use an illustration here. The approach was midline. You make a long incision at the midline. You strip all the muscles from the bones, and most often, in the old school way of doing things, we remove all this bone and all the ligaments attached. So this was the classic midline open approach. This is an example of a surgery I did, although this was for a spine fracture, but just to illustrate the size and the exposure being done here. Retract all the muscles, expose the bone. This is the midline part, the spinous processes, as well as the ligaments attached to them. So this is how extensive the approach is, how invasive the approach is. Okay, a later iteration of the open approach is the mini open approach. The whole idea that if you preserve the spinous processes and ligaments here and preserve the attached muscles, the multifidus muscle in particular, you will preserve stability of the spine even if you decide to basically decompress. So this approach, the side approach, was later adopted in exchange of this big midline approach, and it looks something like this. So for the longest time, I was actually using this approach for doing my discectomies for patients. It's a lot smaller. We can actually do an effective discectomy with this approach. Less muscle retraction, less muscle damage, no midline ligament sacrifice here. Okay, this later, of course, was taken a step further by using a tubular retractor system. This is actually my father over here in 2010, operated on by Dr. Richard Condor, my mentor, the guy who taught me spine fusion surgery in the Philippines. So that's a tubular retractor made famous by Dr. Destando and Dr. Foley. They're different doctors. They thought of the idea independently. Okay, and it's basically a tube that stretches out the muscle so that you can gain access. But in order to do this, you need to have a microscope, an operative microscope. You cannot do this bare eye because there's hardly anything to see here. It's dark and it's small. You need lighting and you need magnification when you do the surgery. Okay, this is an example of how we do this surgery over here, tubular retractor. Instead of making a midline approach, you approach it from the side. You target that location which you want to open, create a small hole, and slowly introduce tubes that are expanding in size. So you slide one tube over the other. It's like sliding a small straw and then followed by a big straw and a bigger straw, and until you reach the diameter that you want, just enough for your microscope to be able to see through it. So that's first tube, second tube, and so on and so forth. Sequentially expanding tubes until you come to the last retractor sleeve, which is this. And then you aim the microscope down here and you do your thing. Okay, so from this approach, classic midline open, to the side approach, mini open, to the tubular retractor approach. As you can see here, this is the rim of the tube. The tube stretches all the way down. That's what you're seeing over there. It's very small, and you need better magnification as compared to this. This you can do bare eye, no problem. But here, normally when I do this surgery, I make use of loops, magnifying lenses. And for an approach like this, you would need an operative microscope in order to do your discectomies, your decompressions. Let's go now to the biportal aspect of the surgery. One scope is for the camera and one scope is for whatever working instrument that you're going to be using. Usually you start off with a drill or cautery, radiofrequency ablator cautery probe. So this thing shows you what's happening on the inside while this thing is working. The nice thing with biportal endoscopy is you can always switch the instruments and switch the holes. So you can bring the scope to the opposite side, the other hole, and do your work there. So it's very versatile. The scope moves independently of the instrument, of the working tool. It's not like in Uniportal wherein everything is constrained by your cannula, by your Uniportal cannula. Here, you can aim the scope and then move your instrument however you want, and the scope doesn't have to move with it. That's one of the big advantages. Okay, this is a patient whom I did UBE discectomy on. You can see how small the wounds are. This is just less than a day. This is the morning after. I operated on her in the afternoon. The next morning, made her sit in bed. She's propping herself up initially with the left hand because there's still some back pain, but very well tolerated. She actually started walking right after this. You can see how small the holes are. As compared to another patient whom I operated on years before this surgery. You can see the mini open approach here. It's not a midline approach. The midline is over here. This is a right-sided approach, and I did that hole. Okay, now why do we want to decompress? What happens to the spine? What warrants surgery to begin with? And I think this is a very important concept that I would like patients to appreciate. Okay, the anatomy of the spine is such that you have a number of vertebrae. These are the bony segments of the spine, and they are basically separated by a disc. This is the core of the disc, the nucleus. It's about 70% water. It's gelatinous, and then you have the capsule of the disc. These facet joints over here are stabilizing structures behind the disc. So the disc will allow motion. The facet joint will also allow motion, but will partially restrict motion so that your spine doesn't go where it shouldn't go. Inside the spinal canal, you have the dural sac, which contains your nerves and spinal cord. So the dural sac is something that stretches all throughout the length of the spine, the bony spine. It connects your brain and spinal cord, basically, or it covers the spinal cord, and then it sends out these branches, the nerve roots, from the side at every level. You can see here. Now, if you if you compress the nerve roots in the lumbar spine, since the nerves that it gives off will go to the lower extremity, the symptoms will radiate down to the lower extremity. See, especially if you compress the lower part of the lumbar spine, you will feel the symptoms from the knees going down. This is the mechanism that how things usually start, how the problem starts. Again, you have the vertebral bodies and the disc that separates them. This is the nerve root coming out of the foraminal canal, the side canal. The disc will slowly degenerate, the core will slowly lose water, and the disc will lose height and will become weak, and then parts of it will bulge. Sometimes the core will outright herniate. And this is what we call a slip disc or a herniated disc. And then, of course, if it herniates like that, depending on the size of this herniation, it can hit one nerve root or it can hit several nerve roots all the way inside. And that's what gives you your symptoms, your pain symptoms, your radiculopathy. If you take that pathologic process even further, you have disc degeneration, disc bulge, disc herniation, and then because the disc can no longer carry its full load, a lot of that load is transferred to the back part, to the facet joints, to the ligament here behind, and you get degeneration or arthritis of the facet joint, which creates stenosis or narrowing. That's basically what stenosis is. So the foraminal canal that allows the nerve root to go out, this canal should be spacious enough, but if there's already degeneration in this area, this will get narrow and will pinch the nerve root. If the degeneration also extends all the way here in the central canal, then even the dural sac will be pinched. So this is lateral stenosis or foraminal canal stenosis. And here, if it happens here, that's central canal stenosis. Sometimes it happens in both areas or in all areas. This is a more detailed look. Again, disc degeneration, the nucleus starts to lose its water, starts to become weak. This weakens or overloads the annulus, the capsule. Loads get transferred to the back. The ligamentum flavum is a ligament that runs throughout the entire length of the spine, and it will become harder, it will hypertrophy, it will thicken in order to carry more load. The facet joints, also now overloaded, will create more bone and will become hypertrophic, will go into hypertrophy in order to carry more load. Now, what does that do? The ligamentum flavum hypertrophy and the facet joint hypertrophy or arthritis or arthropathy, if you would like to call it that, all of those will pinch the nerve structures at the back, while the disc is pinching the nerve structure from the front. So again, stenosis, narrowing from all sides, and you get nerve symptoms. Okay, sometimes there is progressive degeneration and compromise of the stability of the segment in such a way that the vertebra on the top will slide forward. This is what we call spondylolisthesis. This may create instability pain. Now, not all people with spondylolisthesis on X-ray will manifest with instability pain. Not all patients with instability pain will have spondylolisthesis, but majority of them correlate. Now, what is instability pain? It's basically progressive pain in the area that is already affected, in the level that's affected. You feel this in the back. Usually, patients will say that the pain becomes worse the longer the day goes on. They cannot tolerate long periods of standing or walking. Essentially, they get to a point that their activities are greatly disrupted because they have to keep lying down in order to relieve the pain. And then if you do x-rays and MRI scans, if you can find spondylolisthesis, disc damage, facet joint arthropathy, compression of the nerve structures, ligamentum flavum degeneration. So all of that will give you that diagnosis of a degenerated back, a degenerated instability. Just to compare the surgical approaches, from the original classic midline open approach to the mini open approach. This is the classic approach. Patient is on his stomach. You open from the midline. Again, long incision, as I showed you before. You strip the muscles off the bone and you retract the muscles really, really hard, very aggressively. So this actually creates damage on the muscle if you do aggressive retraction. But back then, this was the only approach that we knew. So we would do this, retract the muscles, aggressively do a discectomy, and remove the bone structures in the middle. And what happens is that you basically take out a lot of the vital support structures of the back. And at the same time, you create damage to the muscles that will also support the back. So they said, why not just do a small side approach and make a small window in the bone. Don't remove everything here at the back. Just make sure that you trim that off. You can remove a bit of the facet joint if you want, but we try to preserve the bulk of the facet joint, of course, because it is a load-bearing joint. Okay, just enough space in order to go in, retract the dural sac and the nerve root, and take out whatever it is that is pinching on the nerve root or dural sac. So you don't want to go in and take everything out. You just want to take that degenerated part out. Leave this be, small opening, go in small, go out small, and that's your surgery. And you end up with a small hole at the side, especially if you're using a microscope. You can afford to make the hole smaller. So this is very compatible with the tubular retractor system and with mini open approaches. I'd like to show here what happens if you're too aggressive in creating your bone window. If you want to create space, but if you sacrifice the facet joint in order to get that space, the problem is that you may damage the facet joint or render it unstable, and this will create more stenosis and more pain, more pinching of the nerve root later on. It may result in spondylolisthesis. So among the things that we make a point to preserve would be the facet joint. Okay. Now, if you say that, well, my approach is going to have to sacrifice the facet joint, and that's what they used to do. They would incise wide open, retract the muscles, take out the midline structures with its ligaments and muscle attachments, and then sacrifice the facet joint. So this is called the posterior lumbar interbody fusion. That gets taken out, this gets taken out. So the decompression is really good, but at the expense of the support structures. And then you retract the dural sac, and sometimes the nerve root gets injured because of this retraction. You sacrifice the entire disc, you put in a wedge, a fusion wedge. Now the goal here is to add support as well as material that will cause the two vertebrae to stick together. Basically like a fracture that's healing. So you put in the wedge and you do the same thing on the other side, do another retraction and possibly injure the nerve root here. Slip that in. Now you've got this cavity being held up by the wedges, and then you fill that with bone graft material. Sometimes it's synthetic, sometimes it's natural. It's a procedure done in order to encourage the body to create bony union. You put screws in order to obliterate motion at this segment. So this segment is not going to move anymore, and in a matter of a few months to a year, this will become fully integrated into one whole segment. Now, the downside of this procedure, the upside is you get good decompression. Back pain goes away if there ever was back pain. Radicular pain, radiculopathy goes away because of the decompression. The downside is that since this segment is no longer moving, the motion load that this segment used to carry will now be transferred to the adjacent discs. And we end up with what is called adjacent disc syndrome. These discs next to the fusion level are now going to degenerate much faster. Some will argue that, well, they were going to degenerate anyway. That may be true, but the problem is that because of the fusion surgery, you will eventually end up with more problems here, or more problems at an earlier time. Okay, so it's a trade-off that we used to accept because back then this was what we knew how to do. A more modern approach would be called TLIF, transforaminal lumbar interbody fusion. We use the Wiltse approach, not midline. You cut at the side. So you preserve the midline structures. That's the whole point of the Wiltse approach. Cut here, go in, put in your screws if you need to put screws in. There you go. And you sacrifice the facet joint. That's why it's called transforaminal, because it will enter the foraminal canal by means of a facetectomy. So the goal is take out the facet joints, all of it. Open the foraminal canal, that's your transforaminal approach, and then do an interbody in between the vertebrae, do an interbody lumbar fusion. Open the disc space. You do not need to retract the nerve roots if you approach it like this, and unlike in the PLIF. You preserve the midline structures, so it's more stable, but you still destroy the disc, scrape everything, put in the bone material and the fusion cage. There you go. Put it in, and then wait for it to form bone and basically unite the two vertebral bodies together. Again, it's a fusion surgery approach. You will have to rely on the implants and the wedge here and the bone graft put in to work. You attain good decompression. You can actually extend the decompression all the way to the midline with this approach. And then wait for the fusion to happen. And then, of course, the downside is that you compromise in terms of adjacent disc syndrome. You close the wounds. And as you can see, there's very ample decompression on the operated level as opposed to how it used to look like, but at the expense of sacrificing motion and of course creating more strain on the adjacent disc. So that's TLIF. I did this in my initial phase of spine surgery career. I haven't done one ever since I adopted endoscopic surgery, but this is what I used to do. This kind of surgery was what I used to perform. Okay, let's go to the approach of endoscopic technique, particularly biportal. So it's the same approach, but instead of sacrificing the facet joint or everything here, you just create a small window in the lamina. This is the interspinous ligament. You want to preserve that along with the midline spinous processes. You want to preserve the muscles attached to all of this as much as you can. This is the ligamentum flavum. You can open that up because you need to open that up in order to get down. Create that hole, take out the ligamentum flavum, as much of it as you need to take out, and then go to your disc herniation, wherever that may be, without sacrificing the facet joint. So very small muscle opening, hardly any muscle sacrifice, small bone window, and you can directly go to where you want to go. Preserving stabilizing structures. Again, this is the approach. This is a CT scan 3D image of a patient whom I did biportal endoscopic decompression on, discectomy. You can see the hole I made in the lamina. You can see that the facet joint on this side is intact. Basically this approach. But I've done a good decompression for it. So I've decompressed this part using this laminotomy opening over here. Look at the muscles. This is the side that was not operated on. This is the side that was operated on. That's the port where the camera went in. You can see that the muscles on the operative side are largely intact. You do not sacrifice any of the muscles, or only just a very, very small corridor of it in order to create the bone. Because you bypass the muscles, you come in through the muscle directly to the bone, and then you start work here. You don't need to strip the muscle, these big muscle masses, off the bone. That is basically what we do. And that's why the patients complain of such less pain and are able to return back to activity at an earlier date. Again, the patient earlier, 2 small holes. Patient is sitting, standing, walking the next day. This is an animation of biportal endoscopic spine surgery. So if I want to decompress this disc level, I create 2 small holes beside it. Okay, we stretch the hole a bit in order to accommodate the instruments. One hole is for the scope, the other hole is for the working instrument. Both of them will meet at that particular point where we need to create the opening on the lamina, interlaminar approach. Now the muscles are largely bypassed. We just lift the muscles off the bone at this point, very small area over there. We remove the lamina. Sometimes you remove the lamina closer to the midline, or sometimes it's here. But again, the key here is preserve the facet joint. Do not interrupt the facet joint, and do not interrupt the midline structures. Okay, that's ligamentum flavum underneath there, that yellow thing. So this is ligamentum flavum. This is the laminar opening. The advantage is you can actually decompress even on the opposite side while you're decompressing the same side of surgery. Take out the hypertrophic lamina to decompress, and if there's a slip disc somewhere here, you can just drop down here and do your discectomy. So it's a very straightforward approach, very pinpoint, very targeted, and you hardly destroy anything. Okay, a few questions that commonly arise when I deal with patients needing this kind of surgery. Very basic surgery. Will getting spine surgery paralyze me or result in my paralysis? The answer, of course, is no. If that were the case, then we would not be doing this kind of surgery. It is safe to do. Even the old classic open approaches are safe to do, as long as the person doing them know what they're doing, know the anatomy, know how they're going to go about doing the surgery. Usually among doctors who don't know the process of doing the surgery, they might say to their patients that don't get surgery, you're going to end up paralyzed. And this whole idea gets reinforced from patient to patient. Don't get surgery, you're going to be paralyzed, which is totally not true. Okay, will I be able to return to activity in a short span of time? Yes, actually, and especially if the approach to the surgery was minimally invasive. The bigger the hole, the longer the healing time. The more structures dissected, like for instance when you do fusion, the longer the wait until they heal. Especially in fusion, you're going to have to wait until the bones fuse together. So the waiting time and the return to activity is largely dependent on how big the surgery was. Smaller surgeries require less time, have less post-operative pain. Patients are able to return to regular work and sport even a lot faster. Examples of doing this of these approaches. Okay, a patient of mine here was undergoing physical therapy for treatment of herniated disc. I don't know who told him that was how it was supposed to be done, but as you can see here, he's not improving. He's getting worse. He's using a walker because of pain. I operated on him using a Wiltse approach, a small 1-inch incision. This is the day after surgery. Pain is significantly reduced. He's smiling, but he's still having difficulty walking because he's been walking in pain for months, and he's been using this walker for support. So I told him you should practice not using the walker anymore, because we've already removed this large disc over here, this herniation over here. So I basically approached it that way. So that's how he was walking before surgery. And then he decides, okay, I'll let go of the walker and I'll do more exercise. This is first day after surgery, first post-op day. Look at him on the second post-op day. Let me show you. So this is a day after that, lobby of the floor where he's on. He's walking a lot faster and definitely more confidently. Compare this to that, where he's just basically lifting his left leg. Remember, I did the decompression on the left because his herniation was on the left side. There. Okay, this is more than a week after surgery, and this was in the clinic. He's walking normally now. Hardly any pain at all on the back. So, slip disc, yes, definitely you can address that with a mini open approach. But, other than that, what else? Okay, let's go to endoscopic surgery. This patient had a T8, T9, T9, T10 compression. The spinal cord was being compressed at the thoracic level, and so she was exhibiting with myelopathic gait. Look at that. She doesn't have balance. The legs are weak. They're very slow. She has to look down in order to see where she's putting down her foot. See, it's hard for her to control side motion, let alone forward motion. And she was already walking with a cane when I saw her. This was the day of admission to the hospital. Months later, she's walking like this after I did the basic surgery, which was an endoscopic T8, T9, T10 hemilaminectomy and flavectomy, of course. I removed the flavum. So I did the surgery in such a way that, see, I burred through the lamina. T9 first. I started T9 because that's the center. Then I extended to T8 above and T10 below. And then I removed the dura. Not the dura, I mean, sorry, the ligamentum flavum, which was covering the dura, compressing the dura. She had hypertrophic ligamentum flavum, so that had to go. And because of that, she has 2 small holes at the back and 3 levels of decompressed spine, something like that. And she's walking better. More balance, much faster, more powerful movement. Okay, another patient. This was the patient I showed you earlier. That's the slip disc that I pulled out of her left side. That's that huge bulge over there. Okay, that one. This is the channel through which I did it, a very small laminotomy approach. Now look at the walk. Before surgery, just a day before surgery, when she was admitted, she was walking like that. She could not relax the left side. It was involuntarily spastic all the time and very painful, and had that electric-like radiation of pain down the left leg, left thigh. This was her surgery, 2 small holes. This is the CT scan showing you the opening in the bone, the laminotomy side, intact facet joints, and as you can see with her walk, she is walking more comfortably, no more pain, and she's more balanced. There was a bit of residual weakness, but this recovered over a few weeks. See, the walk is very, very telling of how good the patient feels. Another patient I'd like to share with a large herniated disc. Now, like all the other patients I showed you, they were initially being considered for spinal fusion surgery, interbody fusion. And they came to me because they said, interbody fusion, that's so expensive. Is there another way to do this? And I said, well, yes, you guys are young. You don't need fusion just yet. We can do an endoscopic decompression, and there won't be any instability, so we don't need to fuse your spine. We just need to remove the herniated disc, or the herniated part of the disc. This is an X-ray of this view. So you can see the instrument I used to grasp it. And then this is the camera, the endoscope. That's the thing I pulled out from that cavity, the herniated part of the disc. The patient is under epidural anesthesia, so the patient can be awake during surgery and can move the legs right after. We don't put them under general anesthesia if we can avoid it. Pre-op walk, post-op walk. Now you can see that he's much faster here. He's going to reach the end of the hallway much earlier. He's not slanted to the right. He's not limping. And he has better balance. So that is the result of endoscopic spine surgery, biportal endoscopic spine surgery. So all of this is achievable because we do the surgery. Preferably, we want to do the surgery before the patient starts developing paralysis, before the patient is in a wheelchair. We don't want to wait that long because normally irreversible damage happens to the nerve root or to the spinal cord if you wait too long, if you wait until paralysis is starting to set in. Also, we want to decompress adequately. Now, it used to be that adequate decompression was synonymous with sacrificing your facet joint, your interspinous ligament, your spinous process, and the whole lamina, etc. But as you can see here, that's no longer true. We don't have to create that big an opening. We don't have to remove all those structures. We can restore space, thereby restoring blood flow to the nerve roots, to the spinal cord, with just small openings. Okay, smaller wound sizes, the smaller your surgical footprint, the less anatomic destruction you have. That means you don't render the spine unstable. That means there's very little areas that need healing after surgery, and the patient is happy. Less pain, faster recovery. Oh, and I need to mention less cost also. The patient will ask, can I really recover my life back without needing fusion? Will you need this? Well, okay. If there is already instability before you get the surgery done, then you're going to need this, definitely. It's a definite yes. So preoperatively, if your spine has instability pain, you are better off getting a fusion surgery like TLIF. This is an example of this patient started having pain in her teenage years. She is now 60 plus at the time of treatment. She has a stress fracture. This is a repeating stress fracture of the pars, that area of the spine, and that's why L5 is continuously slipping over S1. And so because it's a fracture, we need to fix it. We need to fuse this, and we need to put screws here in order to stabilize the motion. So that's already unstable even before surgery. Okay, what about this patient? This patient had radiculopathy, did not have back pain, did not have instability pain, but the reason why this patient had radiculopathy was because there's this big tumor over here. It's a nerve sheath tumor occupying the canal where the nerve sheath should be. So this is a schwannoma, a nerve sheath tumor. And in order to remove all of it, I will have to pass through here and destroy the facet joint. So if I destroy the facet joint, that means her spine is unstable, and therefore I am obligated to do a fusion surgery. But if a patient's condition doesn't require you to destroy all these structures, the support structures that are critical to stability, then no, you don't need fusion surgery if that's the case. Okay, will the spine develop instability after whatever surgery you do? So if you do a surgery that doesn't involve fusion to begin with, you just decompress, the question is, well, what happens after that? I get decompressed, but will I develop instability? You won't develop instability for as long as you have preserved facet joints, preserved midline structures, and preferably preserved musculature. If you compromise the facet joint and all the other support structures, then you will develop instability, and you will need a second surgery, which is going to be fusion. If fusion can be avoided, avoid it, especially in the young individual who needs more motion of the spine, who's more active. If we can avoid progressive or more accelerated adjacent disc degeneration that follows fusion, then much better to avoid that. So we only do fusion if it's really, really needed. Okay, thank you very much for your attention, and have a good day.